Okay, guys, I think we're going to get started. Thank you for joining us. My name is Dr. Jessica McLaughlin. I'm one of the physicians here at Coastal Fertility, and this is our Coastal Quickies series. And today we're going to be spending some time specifically talking about unexplained infertility. This has been a great series. It gives a little bit of time to dive a little bit deeper into some of the topics that are specific to our field. So far, we've spent some extra time talking about male factor, talking about age and how that affects fertility. And lastly, we talked about PCOS. And those are all posted so you can see them if you want to go back and use those as a great reference. So tonight we are going to spend a little bit extra time kind of thinking in depth about unexplained infertility. So what we're going to do tonight, we are going to review the basic infertility evaluation. We are going to kind of discuss how we diagnose unexplained infertility. What are some of the common causes of unexplained infertility? And then importantly, what are the treatment options and what are the data that supports what we do? So, to start off with just a definition of infertility, this is the inability of a couple to conceive after a year of regular intercourse without contraception. And this generally affects anywhere from 8 to 14% of Americans. So, I think it's important to know you are not alone. Infertility can be a very isolating diagnosis and feeling, but this is not uncommon, and this is what we're here for. We're here to help. So, when we think about infertility, it's very important to think about what causes infertility, and that helps us to think about, well, how should we evaluate for it? So, first, thinking about just causes, about half of all infertility is related to some sort of a female factor. And we break that up a little bit into that can be an ovulatory factor, that could be a tubal factor, or more in a rare scenario, uterine or cervical causes. There's about 30% that are related to male factors. And then there's, anywhere from 20 to 30% that I see are really a combination of factors. But that leaves about 20% of couples that don't fit into one of these categories. And those are the patients and couples that are diagnosed with unexplained infertility. So when we think about the causes, that really leads to what we should do as far as an evaluation. And I think what's very important is just thinking about this in a very systematic way. So again, starting with the causes, that leads to our points of evaluation. So we're going to start by thinking about the ovaries, and there's different categories and specific questions to ask ourselves about the ovaries. We're going to think also about the uterus and the fallopian tubes. And lastly, we're going to be thinking about male factors, and that's specifically looking at the sperm and a semen analysis. So to think about each of these a little bit more, within the ovary, I like to break that up into two kind of separate categories. The first being just ovulatory function. And actually, history is very good at telling us about this. So, taking a good menstrual history tells me a lot about your ovulatory function. And just from there, we can decide if we need to do other things. Do we need to do a further evaluation for polycystic ovarian syndrome or other causes of ovulatory dysfunction? And then the second thing, which is really critical, which I think Dr. Cook spent some good time talking about, is ovarian reserve. That's what's really affected by age. And the couple ways that we look at that, we start just by looking on ultrasound, doing a resting egg count. And then there's a couple of important labs that we do for ovarian reserve, looking at day 3 FSH hormone, which is the brain hormone that talks to your ovary, and then an AMH value, which is a nice marker for quantity of eggs. So that's everything we're going to look at as far as the ovary. And then it's important just to think about the kind of anatomic considerations. So looking at the uterus, looking at the fallopian tubes, and the way that we do that is with this HSG. And this is a little picture of really what an HSG is. We put a tiny little catheter that sits right in the cervix. You have an x-ray plate on your belly, and then we look at the screen together. What I like about an HSG is it's real-time information. So we are injecting dye that will kind of show me the inside of the uterus. And then if the fallopian tube tubes are open, that dye is really going to flow right out. We're going to see that together on the screen versus it's not coming out, and that's concern for a blocked tube. So that's how we think about and evaluate from an anatomic standpoint. And then for male factor, they just start with a semen analysis. So, what is unexplained infertility? Well, really, this is the diagnosis that we come to when we have a normal evaluation. So, we've thought about the ovaries. We think the ovulatory factor is normal. We don't think there's any concern about diminished ovarian reserve. We do an HSG in the uterus and the fallopian tubes look normal. We do a semen analysis and there's no big red flag. So, unexplained infertility is doing our standard infertility evaluation and getting a normal evaluation. So, why is this happening? There must be a reason behind it. And there are likely common causes of unexplained infertility. And so, we're going to think about each of those. And the first is endometriosis. I get this question all the time from patients: do I have endometriosis? Well, with unexplained infertility, you might. You may have kind of very mild or moderate stage 1, stage 2 endometriosis. And so, this is a little schematic of endometriosis. And so, what endometriosis is every month as a female, the tissue from the inside of the uterus comes out and you have a menses. But actually, some of that goes back out through the tubes. That's called retrograde menstruation. And that tissue in most women just gets reabsorbed by the body. It's a very natural thing to happen. But in a small subset of women, it can stick. It can stick on the inside of the wall of the abdomen. It could stick on the ovary. It could stick on the fallopian tube. And so, really, endometriosis is normal tissue in an abnormal location. And so, some of unexplained infertility is likely kind of mild endometriosis. And endometriosis affects fertility when it's severe, when it causes anatomic distortion. So, a lot of times with stage 3 or 4 disease, we're seeing cysts on the ovaries or we're seeing a fully blocked tube. But with kind of milder disease, it's very possible that it's there and affecting fertility just because it's causing a different inflammatory environment in the abdomen. And so, some of unexplained infertility is certainly related to a mild or kind of early stage endometriosis. We can also, we suspect that there's pelvic adhesions that contributes to unexplained infertility, and they're not so severe that they're fully causing a blocked tube, but they are causing some anatomic distortion, and then more subtle abnormalities in egg and sperm that are really outside of our kind of initial screening testing. So this is a question I get all the time. Should we do a laparoscopy? And if you ask reproductive endocrinologists 30 years ago, the answer would be yes. Really, everybody with unexplained infertility used to get a laparoscopy, but we don't do that anymore. We fully recognize that some of unexplained infertility is probably due to endometriosis or pelvic adhesions. But we have spent a lot of time thinking about this and studying this, and we know that a couple things. Surgery is expensive, first of all, and it certainly has risk. So, doing a surgical procedure, we are always thinking about risks and benefits of, putting instruments into an abdomen, risk for bleeding, infection, damage, other things in the belly. And importantly, what we know is really surgery alone is not going to improve success rates either on your own or with doing fertility treatments. So, even if we went in the belly and found a little spot of endometriosis that was on the sidewall of the abdomen, whether we went in to determine that or not is not going to help us either achieve a pregnancy on our own or when we're doing active fertility treatments. And so, everything is about weighing risks and benefits and thinking about what is the most cost effective and safest care for you as the patient. And so that's why it is no longer standard of care to do a laparoscopy with unexplained fertility. But we certainly do recognize that these are causes, and we think of other treatment options other than surgery. So, since there is no treatable, identifiable cause, the really treatment is by necessity, it's empiric. And that empiric treatment, importantly, is really twofold. And it's important that both of these are combined together. We're going to talk about both of them in detail. So, it's combining two different tactics. One is ovarian stimulation. We're going to talk about what that entails. And the second is intrauterine insemination. So, ovarian stimulation, this is an example of how we've kind of stimulated the ovaries. It's giving you medicine to help the ovaries form more than one follicle, more than one egg. And so, the goal is to improve pregnancy rates by increasing the number of eggs that are available to meet sperm. So, these are all kind of eggs and follicles that we've stimulated. They are nice, big black circles because actually they're mostly fluid filled. The egg is in there and it is microscopic. And there's a couple of ways to do this. So there's different medicines we can use. There are kind of two categories. The first being an oral medicine, and the common ones, that you may have heard are an older medicine called Clomid or clomiphene, and then letrozole or Femara. And then injectable medicine. So if you hear about injectable medicines in fertility, those are actually gonadotropins. What that means are those are brain hormones, FSH and LH, and we're just giving them back to you as little subcutaneous injections. And those are really the two categories of medication we can use for ovarian stimulation. So, what we do is we're giving medicine to stimulate the ovaries, and we're trying to form more than one follicle. So, naturally, you form one follicle on your own each month. We're going to give medicine to maybe form two or three follicles. So, to increase the number of eggs that are going to be ovulated. When we're doing this, it's very important to be monitored in a couple of ways. So we need to be doing some ultrasounds and also monitoring blood levels, because as the follicle grows, as that egg grows, it's going to increase your estrogen level, and that's something that we can track. When the follicles are big enough, that's what we're waiting for. We're going to give you a medicine that's going to help you to ovulate, and you're going to ovulate approximately 36 hours later. And so this is a very controlled ovarian stimulation. We're monitoring the whole time, and then helping you get ready to ovulate. And so, after we've given that medicine to help you ovulate, that's when we go into kind of part two. And part two is called intrauterine insemination, or an IUI. And basically, sperm is kind of wash and concentrated. Every guy has dead sperm and debris. It's normal. And that is kind of put into this little catheter, and that little catheter is put up to the top of the uterus. So naturally, with intercourse, sperm's weeded out in the vagina and the cervix. Again, totally normal. But what an IUI does is it gets a very high concentrated sperm up to the top of the uterus, and it optimizes timing. So we're doing this to time it with ovulation. And so the combination of ovarian stimulation with IUI are what's going to increase pregnancy rates. When we do anything, it's important to think about the risks. So, the main risk really to know about with ovarian stimulation is multiple pregnancies. And so, we are intentionally getting you to ovulate more than one egg. And with that comes a risk of multiples. And so, when we use a medicine by mouth, the Clomid or letrozole, generally that risk is approximately 10%. Most of the time, that is twins. Very, very rarely is it anything higher than twins. When we add in the injection medicines do have higher success rates, but the downside of injections are that they're also going to have higher multiples rates. So that multiple rate goes to about 15 to 20%. So again, one of the really important reasons that we're monitoring you during this time. We need to know how many follicles you're forming so that you form an appropriate number. We're getting a nice response, but also not an over response. And so that's why it's very important, again, to monitor. The second risk to know about is actually pretty rare with this type of treatment, and that's ovarian stimulation syndrome. So, that is a syndrome that's related to having a very high estrogen level in your body that causes abnormal fluid shifts. And so when we take medicine by mouth, the chance of that happening extremely rare, under 1%. When we add in injection medicines, it potentially is slightly higher, but again, overall, very low risk, under 5%. And most of the time, if women have any symptoms, it's mainly kind of a symptom of feeling bloated. But this is something we recognize. We don't want to overstimulate the ovaries. We want to monitor you, but it's still a low risk just to know about. Oh, we have one question.
This is Carly. She wants to know, what are your thoughts on using essential oils while undergoing fertility treatments to help regulate hormones, specifically during IVF embryo transfers?
So, this is a great question, and we get this question all the time. When using kind of supplements or outside medicines, they all have the potential to interact with the medicines that we're trying to give. And so, in general, if you have that specific name, you can kind of bring it to your doctor. But in general, we're not recommending any additional supplements or essential oils. We really want to, we're a little bit of control, people. We want to be in total control of what's happening with your ovaries. This is a big deal to undergo, whether we're talking about ovarian stimulation or, like you're talking about with IVF. And we really want to give you your optimal outcome, and have the most control over that. So generally, essential oils, supplements, unless it's a medicine that we're giving you or we've talked about, in a new patient consult or follow-up consult, generally avoiding those outside things. Great question. So there's lots of medicines to use. So what one should we use? So at Coastal Fertility, our approach to unexplained infertility is, like we talked about, combining the two things, combining ovulation induction and intrauterine insemination. And we use a combination. So we use a combination of an oral medicine called letrozole and then a low dose of the gonadotropins. And we believe this to really optimize your success rate and give you the most cost-effective care. So the injection medicines help to increase success rates with this. But they also can be costly and cause multiple pregnancies. So we use a low dose with a hybrid protocol, to really kind of optimize all facets, from success rates to cost-effective care. So what are the success rates? I think it's important to just think about, well, let's think about unexplained infertility. A couple comes to see me, they have unexplained infertility, they've been trying for over a year. The important thing to know is your success rate still on your own is not zero, but it's probably low. It's probably in a 2 to 4% range after a year of trying. I always like to put this into perspective of what's normal. So let's take a 30-year-old couple that comes to see us. They don't have any fertility problems. They're just trying to start their family. And they probably at most have a 20% chance of conceiving each month. So again, it's not zero when you have unexplained infertility, but it's probably low. It's probably at 2 to 4%. So using, our ovarian stimulation with intrauterine insemination with the medications that we generally start with, we're going to really increase that success rate back to baseline. So per cycle, we're going to have success rates in a 15 to 20% range. And so, why we do what we do really comes from actually a lot of medical literature. So it's very important, to be practicing, evidence-based care. So when we think about unexplained infertility, we have, a couple really big studies. We follow our guidelines from the American Society of Reproductive Medicine. And what we know is in patients under 38, we have really good evidence to support that first line treatment is really with 3 rounds, so we're trying 3 times of ovarian stimulation with intrauterine insemination. And then after that, if we're not successful, hopefully we are. We always want you to conceive with simple things. But if we're not, we have good evidence that really the most cost-effective and fastest time to pregnancy after that would be to consider more aggressive things like in vitro fertilization as the next best step. And so all these studies come from actually big studies in a statewide population where there's, state covered fertility care. It's easy to study. I wish that was the case for everybody, but what we found is 3 rounds of ovulation induction with IUI. And if we're not pregnant at that time, considering kind of moving on to more aggressive treatments. So what we've also found are things or interventions that don't increase pregnancy rates over baseline. And this is also a very common question I get. So specifically with unexplained infertility, it's very important to combine ovarian stimulation and intrauterine insemination. So if we do each of them individually, they really don't increase your pregnancy rates from baseline. So if I just gave you medicine to stimulate your ovaries and you had timed intercourse at home, we know that really doesn't increase pregnancy rates. On the other side, if we said, well, let's just allow a natural cycle, you're naturally going to form one follicle, but let's pair it with an IUI in the same way, just doing kind of half of it does not improve, pregnancy rates over baseline. The other thing we found in studies is that doing double IUIs does not improve pregnancy rate. So what a double IUI is a question I often get, is after we've given the medicine to stimulate ovulation, we're kind of doing an IUI and then 24 hours later, doing a second IUI. So the theory behind that is there's more sperm there. We must be increasing pregnancy rates, but we have good evidence to show that double IUIs, do not increase pregnancy rates over the single IUI. So again, we're always trying to think of what's going to give you your highest pregnancy rate and what's going to be kind of cost-effective care for you. So a single IUI, paired with ovarian stimulation would be our recommendation. Now, what about in patients that are in a little bit of an older age group? Let's talk about patients that, are maybe 38 to 40. So in general, there is, fairly good evidence that to consider more aggressive treatment in this age group. So in women over kind of 38 to 40, that's when we at least start a discussion of maybe we start with something more aggressive like in vitro fertilization. And what we found again in these studies is this is going to be kind of your shortest time to pregnancy compared with kind of trying simpler things first, and then if not successful, moving on to IVF. So my thoughts, and to kind of finish us up here, I think that unexplained infertility can be a really frustrating diagnosis. I know that you want something to hold on to that we can identify and just fix. So I know it's frustrating, but also know this is 20% of our patients. You're not alone. And we have really good evidence actually to guide us on what we should do. The other thing I would encourage is be reassured. Actually, this is a good prognosis kind of patient population that does well with simple treatment options. So, like I said, we always want you to, if you can, get pregnant with simple treatment options. And so, this is, really the starting treatment for unexplained infertility. And I think the other thing to know is that care is always going to be individualized. So yes, we have these big studies and these guidelines, but it's always going to be a discussion. This is just a roadmap. And so you as a person or you as a couple are always going to receive individualized care, but this can at least give us some guidance and some evidence in what we should be doing. So thank you so much for spending your evening with me. If you want to continue this conversation, you can either kind of find us online or just by calling and to make a new patient appointment. We are going to continue our series, our Coastal Quickie series, and I think next time spend a little bit extra time thinking about endometriosis. So at this time, I'm going to conclude. I hope everybody has a wonderful evening. Thanks for joining us.